Hello, I'm Dr. Rosen, and I want to thank you for coming to the conference today. And this, as you know, is ultrasound for the liver, gallbladder, and pancreas. Now, for those of you who are relatively new to ultrasound, I'll just give you my personal bias. I think clinically the ultrasound exam for the liver and gallbladder are quite important in the emergency department and in the intensive care unit as well as general medicine. The examination of the pancreas is somewhat more difficult, and we'll get into that in the lecture. CAT scan is the gold standard test for looking at the structure of the pancreas. The pancreas can be somewhat difficult to visualize, and you really need to know your landmarks. So when it comes to ultrasonography, gallbladder, the examination is crucial, liver, super important. Pancreas, it's nice to know. But just realize that ultrasonography does have its limitations. But additionally, flip side, ultrasound can still be useful. Well, let's get into it now. So, as most of you know, there are many different types of probes. So, to examine the organs that are in question here, we're going to use a probe that's a low frequency, where we can look at deep organs. So we're going to use a phased array probe or a curvilinear probe. So the P17 or P21, beginning with P for the word phased, and the C60 in this case, another low frequency probe, beginning with the word C for curvilinear. And these probes, again, as a general rule, we all know, typically point to the patient's right or to the patient's head. And we're going to be examining the organs in either longitudinal, transverse, or coronal planes, and typically you want at least two of these views. So what I do is, for examining the heart, I look at the liver first and then find the heart. For examining the liver, I look at the heart first and then move to the liver. So since we're talking about the liver, I'm going to locate the heart, which is relatively easy, and then slide over to the liver. So we put the probe in the subxiphoid position in the longitudinal plane, and we'll see the right tip of the liver with the heart. Then we'll slide the probe down to the margins of the right ribs, and we'll visualize the liver and gallbladder. Now, occasionally, it can be difficult to visualize the liver and gallbladder from this angle. Sometimes the patient has a lot of gas, and you can't compress all the way through the gas to see the gallbladder. And sometimes the patient's obese. In that case, going to the coronal view on the side is particularly useful. Now, when you go to the coronal view, you really need to think about what probes you want to use. I happen to prefer phased array probes for the gallbladder. Many people prefer the C60 probe, the curvilinear probe. But when it comes to doing a coronal view, you're going between the ribs. So the curvilinear probe has a larger footprint and can fit between the ribs as well. So many people would prefer at this point to switch to the phased array probe, which can more easily fit between the ribs. Your choice, but just remember you have to deal with the ribs if you go to the coronal view. So first we'll start off with the subxiphoid view. Now in this clip we see the liver at the superior part of this image, and then the heart surrounded by pericardial effusion. We now have our landmark where the liver is, and we just slide down to the right ribs to see more of the liver and the gallbladder. Now remember that when we go from the superficial anatomy, the skin and the subcutaneous fat, and we go up to the level of the chest, since we're aiming the probe up, the beam is going up, the image will appear on the bottom of the screen when it's further into the body. So as we go up away from the probe, we're going down on the image. In other words, the top of this screen is skin and subcutaneous fat. We then traverse the liver. On our way up towards the head, we hit the diaphragm. And over here we see the inferior vena cava labeled as such. Now the liver is a very vascular structure, which helps differentiate it from any picture that has a diaphragm and a liver-like structure in it, which could be spleen. Very avascular compared to the liver. Sometimes you can't see all the vascularity, but just by changing the axis of the probe by 5 degrees or so, you can get this image. Now in this image, we have the liver marked with the green arrow, and we have the hepatic veins draining into the inferior vena cava at the inferior aspect of this image. And the hyperechoic structure at the bottom is of course, the diaphragm. And obviously, this could not be mistaken for a spleen. So again, skin, liver, IVC, and diaphragm, with the ultrasound beam going from the top of the screen going down. And if you think of how the beam is aimed on the patient, it's going from the skin up to the diaphragm. Now here's a clip of the spleen, which is rather large, and you'll see typing appear on the left side of the screen saying big spleen. And note the lack of vascularity in the spleen. And on the slide you can see also the question, can you see the kidney fluid in the splenorenal pouch and the general ascites? So the kidney is at the inferior margin of the screen. It'll appear shortly. You can see the hyperechoic space between the spleen and the kidney, and there's the ascites on the right of the image. Now, when we think of a patient who has cirrhosis, on physical exam, the liver is shrunken, it's hard, it's nodular, and we can see signs of that on the ultrasonographic exam. So as the liver shrinks and scars, with cirrhosis it becomes hyperechoic, relatively avascular, with a scalloped edge. And over here is a cirrhotic liver, the green arrow pointing to ascites, where it's anechoic. And the kidney, the space between the kidney and this cirrhotic liver is Morrison's pouch, and there's obviously fluid in Morrison's pouch because of the massive ascites. And here's an image of a very typical cirrhosis patient. And again, notice that the liver is exactly what you would expect to feel on physical exam. Small, shrunken, nodular at the edges. And you could imagine that this would be a firm liver, hard liver. Not hard, but firm. This is an image of a 34-year-old who had fevers in Honduras and had some right upper quadrant pain. Gallbladder was normal, but this was found on the patient, and it was quite tender to palpation with the probe. This is a very large, somewhat cystic structure that measures over 5 centimeters at this margin here. And this was drained in the hospital and proved to be an infected liver cyst. It's a different patient, 51 years old, with abdominal pain and weight loss. And you can see from this clip, you can hardly even tell this is liver. There's no vasculature. The architecture of the liver is completely off, and you can make out these gross nodules. And this is a patient who has cancer of the liver. And in various aspects of this clip, you can see hypoechoic areas, and that's fluid that is collected from the ascites related to this liver cancer. Now, here's a mass that was found on an ultrasound. And as you can see at the bottom left of the slide, it measures 6.1 centimeters by 5.87 centimeters, so approximately a 6 centimeter mass. This patient came in with right upper quadrant pain, and an ultrasound was obtained at first looking at the gallbladder. Well, how was this liver mass found? So here's the ultrasound of the gallbladder. Here's the gallbladder here. The walls are somewhat thicker than normal, as we'll find out, but as we fan through the gallbladder, we can see that at a certain point, the mass appears. And there it is. That's the mass in the liver. So the moral of the story here is, when you're looking at one structure, don't ignore the surrounding structures. There's a reason why this patient has a thickened gallbladder, and that's due to the ascites, which we can see here. And there's a reason why this patient has ascites, and that's not due to his gallbladder disease. That's due to the liver cancer, which was proven by biopsy of this nodule. This mass, actually, not a nodule. Now, the most common reason by far, of course, of looking at the gallbladder is to rule out acute cholecystitis. So what do we look for? First thing is we want to see if the patient has stones. And if he doesn't have stones, is there sludge? Sludge is basically sand in the gallbladder rather than what amounts to a pebble. And it has a sand-like quality not only when you're in the operating room, but also radiographically and sonographically. And then we look for fluid around the gallbladder, or pericholecystic fluid. We measure the anterior wall of the gallbladder, which is normally less than 3 millimeters. If it's greater than 3 millimeters, then the gallbladder wall is thicker than normal. Why is it thicker than normal? As with any inflammation, gallbladder can get edematous. And when the gallbladder has enough edema, some of it weeps around the gallbladder, and that gives the pericholecystic fluid. And we'll see later why we measure the anterior wall of the gallbladder. There's a lot of artifact on the posterior wall. Then also we'll measure the common bile duct. The internal